My talk is on hemodynamic support in chip. This is a very big talk, big topic. I would like to cover a few basics. So as we all know, there is a continuous evaluation on PCI technology and techniques. So that in our day-to-day practice, we are doing more and more complex cases. So this is a continuous process. So that is enabling us in our day-to-day life to deal with more complex cases in current in recent times. So even that is statistically proven in AHA studies that nowadays PCAs are more compared to any other revascularization techniques. And we are doing more number of almost in one of the analysis, double number of left main PCAs compared to previous decade. And there is significant increase in interventions on LV dysfunction patients, as well as we all know now we are doing more and more C2O cases by various technologies like antigrade, retrograde, and multiple techniques. So this this has led to a high risk PCI is emerging as an valuable therapeutic modality in a in some patient scenarios and in a population, growing population of patients known as complex, high risk, and indicated procedure, that is the chip. So though the chip definition is not very clear and not uniform across the globe, we can take majority of the complex circumstances and complex scenarios to define the chip. But these patients actually who needs more interventions are most probably denied because of lack of support or because of high risk. But with hemodynamic support available nowadays in the form of mechanical circulatory support devices, we are attempting more and more PCI cases. Otherwise, we were ending up in doing incomplete revascularizations most of the times, or we were staging the procedures, one stage, two stage, where by doing a repeat interventions, we were inviting more troubles. So what patients are we talking about? What are those patients? So we are talking about the group of patients known as protected PCI group. The protected PCI group is a complex group. It's a confluence of patient characteristics, three major patient characteristics like patient comorbid conditions, complex coronary anatomy disease, and hemodynamic subset. So if you look at the patient comorbid conditions like heart failure, diabetes, advanced age, or severe peripheral vascular disease, or presentations with ACS like unstable angina or NSTEMI, or patients who already had surgery, again going for a repeat surgery is a high risk for them. And if you look at the complexity of the coronary anatomy, we are seeing more and we are doing more and more, and we are seeing more and more complexities nowadays, like left mains, multi-vessel diseases, as well as bifurcation diseases. So, and we are using more and more gadgets like atherectomy. So far, we have discussed so many things, how to optimize the PCI results. So whenever we use all those gadgets, ischemic burden and ischemia time will increase, so that there are chances that patients may crash on table. So for them, we need a robust mechanical circulatory support. And if patients are experiencing already having a hemodynamic compromise in the form of low ejection fraction, then they are at high risk. So all these factors, if present in one particular patient, they are known as a protected PCI group. If you look at the these factors in more detail, if you look at the anatomy, if it is a last remaining conduit, definitely that's a high risk. So you cannot meddle with the last remaining conduit just like that without any support. And if you are planning more atherectomy devices, more atherectomy in a complex bifurcation lesion or left main, disc left main or something like that, then you need some hemodynamic support. And if you are anticipating high ischemic burden or extensive revascularization, sometimes we do multiple like bifurcation, two bifurcation at a time, or sometimes we are dealing with disc left main bifurcation. That substance most of the myocardial territory, then he needs hemodynamic support. And especially if we are doing a CTV intervention, retrograde approach and all those things needs that. And looking at the patient comorbidities like COPD, severe anemia, and renal failure, these are all because we are doing these chip procedures in an advanced age group. All these comorbidities are we see more often, and peripheral vascular disease, where the managing the distal pulses and all will be a challenge. And we have special strategies for that. And hemodynamics, all these things are very, and this is a very simple algorithm. If you understand this, and it's better way, who needs the hemodynamic support and who can, without hemodynamic, we can do in a given patient. So if you look at the ejection fraction less than 40%, they recommend that we need right heart catheterization to understand the cardiac index, to understand the wedge pressures, to understand the EDP and PA saturation. All those things we have to calculate if EF is less than 40%. And we have to see all these factors, like if cardiac index is less than 2 or PA saturation is less than 55%, it carries 2 points. And if syntax score is more than 22, it carries 1 point. Ejection fraction less than 25%, 1 point. And systolic BP less than 100 at baseline, 1 point. And if the presentation is like ACS, unstable angina, NSTEMI, the 1 point. And planned revascularization more than 2 territories, like disc left main or bifurcation, LED diagonal, D1 bifurcation, something like that. And there is a likely prolonged ischemia, like you are attempting a retrograde CTO and atherectomy, complex atherectomy. All those things will carry 1 mark. And severe MR, if is present in a given case, again, 1 point you can take. And decompensation state by doing a catheterization, like if LVDP is more than 20, or if patient is experiencing new onset orthopnea, and high risk vascular injury or significant bleeding you contemplate in a given patient, or if HB is already low. So all these parameters you have to see, and you have to calculate the uh, uh, points. Then if the patient is scoring only 0 to 2 points, then probably you can get away without any hemodynamic support. You can do a simple angioplasty. But if there is a patient is carrying 3 points, consider support. More than 3 points, less than or more than or equivalent 4, then strongly recommend and strongly consider for hemodynamic support. So if you look at the benefits of mechanical circulatory support, it maintains the vital organ perfusion, and it reduces intracardiac filling pressures, so that patients will pulmonary edema on table and congestion and all those complications we can avoid on table. And it reduces the left ventricular volumes and wall stress. Thereby, it increases the it reduces myocardial oxygen demand and consumption. And it also augments the coronary perfusion. These are the basic principles, basic ideas behind the mechanical circulatory support. And the options for that, we all know IABP and Impella are on cardiology side, and we have tandem heart and ECMO, mostly used by our surgical colleagues. But nowadays, because of percutaneous device and we are using that often. So the first thing is a crucial decision here is whether to take IABP or Impella. So IABP, we are all well versed with the IABP placement, and it's easily available. So here the main thing to decide between these two is the availability, ease of use, and cost. Especially in India, the cost is the biggest factor deciding about between these two devices. If you see a patient who is having active ischemia, ongoing ischemia, then probably you can start with the IABP placement. Then if need arises, you can convert them, or you can take Impella as and when required. But if they are already in failure, some sort of failure or end organ ischemia is noticed in the form of raising lactate, and better to take Impella device. So this is the Impella pump family. So like iPhones, we have iPhone Pro and iPhone Pro Max, something like that. We have Impella 2.5, Impella CP, and Impella 5. So these are all used by the percutaneous techniques, whereas Impella 5.5 is a surgical device placed by cut down from axillary most of the times. And we have even Impella right side RP for giving the right ventricular protection. Whenever there is a RV failure, you can consider Impella RP. So these are all the heart of the Impella, but this is the brain, what is known as automated Impella controller. Lot of things we can control from this monitor. So if you look at the hemodynamic effects of Impella, it by increasing the flow, so it aspirates the blood from the LV and it delivers into the aorta. So by continuously pumping, this is the axial flow pump, continuously pumping the blood, so it increases the flow and it increases the mean arterial pressure. Thereby, cardiac power output will be increased and end organ perfusion will be better. And it decreases the LV EDP and end arterial pressure as well as volume, so that LV wall tension will come down, and it decreases the microvascular resistance, and it leads to increased coronary perfusion so that oxygen supply will be better. And also it decreases the mechanical work of the heart because it's pumping in place of the heart. Heart need not to work hard. So mechanical work of the heart will come down and oxygen demand will be less. So this is another simple algorithm developed by Mount Sinai group. Whenever you are taking a patient with LV ejection fraction of more than 35%, if it is a simple PCI, then probably no support is required. If it is a complex PCI, which is complex PCI defined as a long calcified lesion, bifurcation lesion, or unpredicted left main, or SVG lesions, these are all complex lesions. If you are dealing with a complex lesion, probably you may need Impella support. If the ejection fraction is between 20 and 35, simple PCI, sometimes you can consider Impella, but if it is a complex, definite Impella is needed, especially in high syntax score and high STS score patients with whenever you are planning high risk PCI. And once ejection fraction is less than 20%, so without hemodynamic support, we should not touch the patient. So this slide explains the simple principle, how Impella helps the patient. The patient's mean arterial pressure to start with is 86. Whenever we inflate the balloon without any support, so there will be a drastic decrease in mean arterial pressure without support. So it reaches to almost all half of the map in just 30 to 45 seconds. So if we are doing a pronged ballooning, or if you are doing like some atherectomy, then there are chances that the patient will crash on table. But whereas with Impella, then initially the map will be, the mean arterial pressure will increase. Then when you inflate the balloons, the decrease will be very less, and it reaches a steady state of whatever more than the required mean. And when myocardium will go into hibernating state, it will never will allow the patient to go to ischemic down cascading. And whenever you inflate, this is one important phenomena you notice on the table. This is termed as ventricular arterial uncoupling. So ventricular arterial uncoupling is your left ventricle pressure will go down, but Impella will maintain the pressure so that the end organ perfusion, mainly to the brain and kidneys and other, will be maintained by the Impella till the heart recovers. So other hemodynamic support, what we discussed is ECMO. So we all know what is ECMO and what are the various VA, VV, ECMO, but it's not routinely used for hemodynamic support in PCI unless a patient is having biventricular failure, or patient is already in SCI D shock, or probably at the SCI E with ECP or something like that. Otherwise, we don't routinely use ECMO. So these are all circuits possible with ECMO device. And so, yeah, I'll show you few case examples. 61-year-old male, a diabetic, old interval MI, he underwent PCI long back, again presented with ACS like presentation, unstable angina. So now EC showed old interval MI, echo ejection fraction is around 30 to 35%. And he developed acute LVF on table after angio. So then we decided to go ahead with the viability study, and the viability was good. This is the lesion. You can see the distal left main, very calcific lesion with poor targets, diffuse LED disease, and distal left main disease. And this is a dominant circle. One more important aspect is whenever you are dealing with a dominant left system, you are attempting distal left main, always better to use the robust hemodynamic support in the form of impella. So yeah, this is the angio. You can see the distal LMC having a very protruding calcium nodule there. So based on the various risk factors, we decided to take the impella, and we are placing the impella, and with that support. So see, even the imaging catheter was not going. We were struggling to push the imaging catheter. Such a tight stenosis was there. So if you touch that patient without impella, probably he would crash. So we have done the ostial ballooning, and we have done the OCT run, and we have done the DK crash technique we have done, and POT. This is a final result. So to achieve such a good result without any complications, definitely we need hemodynamic support. And this is the second case who is hypertensive diabetic post-COVID, anti-MI with severe LV dysfunction. Again, parented with TVD. PET, we have done the PET, showed the viability in all territories. But first, they have done the staging process because LAD is a CTO. So they did only the other hospital, they have done only RCS stenting and left the LAD. But again, we have done the PET in April. So again, there was a viability. So we thought we'll attempt because he is having LV dysfunction and viable myocardium. So again, we took the help of impella support, and it was very difficult, almost tough, long ischemia time and all, and a lot of balloons, lot of gadgets we have used, microcatheters and all. So finally, we crossed the lesion and we stented from LM to LAD with the help of guide extension there. And yeah, this is the final result. And after 6 months follow-up, his ejection fraction improved, and he's almost mild LV dysfunction now. This is a OCT after this thing. So in summary, routine use of hemodynamic support device is probably not necessary in our day-to-day life, but there are scenarios where we have to individualize for each patient, and we have to make very early decision before going into before taking the case. We have to decide whether he needs any hemodynamic support or not based on the one algorithm we have shown. Probably that helps in deciding whether he needs or not. Then in this, we are familiar with IABP, and now the usage of impella is going up. With that BCIS 4, after that, the IABP usage is doubtful, but impella is showing prominent results in real world studies and almost all random trials. Now I think they are doing a Protect 4 trial that will give more idea about the usage of impella in more number of cases. Thank you.